can't seem to find mine. I'll just go around and check. I'll be back.
Yeah, sure.
Okay, fine, perfect. Thank you.
So there's probably your sequence is third, sir.
Okay.
So Dr. Karthik will have the first PPT, followed by Dr. Muna Bende, and then yours, then Dr. Rupak Roy from Calcutta, and then last is Dr. Borse.
Perfect. All the better. Okay.
Yeah.
I'll see you soon. I'll be back in about 3 or 4 minutes, 5 minutes. I'll let you
take your time, sir. Maybe 10-15 minutes is also fine. At 11:05 we'll start.
Perfect. Okay. Yeah. Thank you. Bye-bye.
Thank you. Hello, sir.
Hi. Hello.
Dr. Unni just came and did a slide share, and it was okay.
Oh, awesome. Okay.
And he has gone to get some headphones.
Okay. Hello, Dr. Karthik. And he's also gone somewhere.
So there is a 30-second lag on the YouTube.
Okay.
And we are already live on YouTube.
Okay.
So Dr. Borse has requested to keep his talk as last.
Cool.
I'll just call up Dr. Muna, madam.
Sure.
Hello, madam. Madam, another 5-10 minutes for you to join, or you are ready? Okay, okay, sure. Yeah. Karthik has the first PPT, followed by you, then Dr. Unni, then Rupak. No problem. Yeah.
Hi, how are you all?
All good, sir.
Good morning.
Good morning, Karthik.
Hi, Swapnesh. Hello, sir.
Hi. Hi, Oli.
So you're muted.
Yeah, I'm just unmuted. Good morning, everyone.
Morning, sir.
How are you, Oli? How are things in Kerala?
It's Onam today, so happy Onam to all of you.
Oh, happy Onam. Happy
Happy
Onam.
Onam, happy Onam, Unni.
Yeah.
Nice to see you. It's
Yeah.
like a hospital in the background.
Hospital in the background. Let's see. Just the building is the most cheerful thing now. What's happening inside isn't.
Good morning, Dr. Karthik.
Morning,
Hi,
sir.
Nikki.
Hi. How are things in Kerala?
It's okay. Trivandrum has taken a bit of a hit, but the rest seems to be okay. Anyway, bad policy, poor policy, who cares? I mean, what has to happen has to happen.
That's true.
Yeah.
So, Swapnesh, what is the flow? Everybody knows the flow.
Yeah. First, Dr. Karthik. First, sir, you will give the introduction, followed by Dr. Karthik's PPT, then Dr. Muna, then Dr. Unni, then Dr. Rupak, and finally we have Dr. Godse sir's presentation.
Okay.
And this is live on YouTube as well as our Facebook page.
Awesome.
So most of the participant attendees will be on YouTube or Facebook, so that we have a better transmission on our platform.
Okay.
Okay. That's good. So, Preetham, you all are going to have a lot of time in Zoom today, morning and evening both.
Yeah. It's a long day.
Long day for you all.
But that's a good thing. Dr. Usha Jori has kept it at 7 p.m. So
Yeah, I know.
So people are going to your hunger and hypoglycemia is going to play a role in ending the AGM soon.
Yeah. Well, I think since it's a virtual, maybe it might end up faster.
Probably. True.
Yeah. See, when it's live, the issues go on and people go on expressing.
Yeah. No, but the thing is, in physical, you barely have attendance, 80, 90 people. Here on Zoom, the attendance, I'm sure, might be more, I think.
Quite possible. Good. And if the attendance is good, then people might just shift to a virtual AGM.
Seriously. That might be a new normal.
Yeah. So are we shifting the focus to January or something? Or no focus this time?
I don't know. We're thinking of maybe even in Jan. I don't think physical possible hoga Jan Feb May. If at all, we might have to have a virtual meeting. If at all, I feel.
Okay.
I don't know whether in Jan, Feb, March we could have a meeting, with 1,500, 2,000 people and the trade. Good stuff, difficult. I mean, from the medical point of view and even from the logistics point of view, whether we'll get that many sponsors, how much, all that.
Only in the Retinal hall we have the social distancing.
By default.
By default. So maybe only Retinal hall. The rest all will be virtual.
You might call it Retina cum isolation hall.
Actually, according to new guidelines, 100 people are allowed now for any function from from 14th of September
From
or 1st of September.
21st, I think.
21st.
21st September. They're starting schools also, they said, with some 50%. I don't know what it means. Schools with 50% capacity.
No,
That's on
50% teachers can go.
Okay.
9, 10 students, 9th standard, 10th standard students can go. So as soon as Dr. Munna joins, we'll start with the introduction. It's almost 11.
Yeah. Madam
Yeah, I think we should.
Madam is joining.
Yeah, she called me.
Even Kamlesh Kumar ji is here, na? Good morning, Kamlesh
Yeah.
Kumar ji. He is muted.
Swapnesh, how can I see you twice? Yeah, logged in as.
Yeah, because it's running on my home internet. So I have one on PC and one on the mobile internet.
Okay.
How is the OPD picking up at Mumbai, sir?
Nishi.
Picking up, see, we are just able to start now. Forget picking up. I think that's where it is. We have just started to go to the clinic and the staff can still come in. That's what we have achieved now. Otherwise, it was very difficult. Surgeries, I don't think they are a far cry from what they used to be. Even the OPD, I think is about 30-35%. That's it.
Yeah.
I think that's across the board.
Is public transport available now, sir, in Mumbai, or it's still under lockdown?
Only the buses are available, but that too limited, and trains are not there. Taxis are not running so freely, and half the taxi guys themselves are not in Mumbai. So that's another problem. It's difficult. Maybe another 2 months at least. I think till Diwali, maybe. We need to wait.
Probably.
So should
I
we
think
start?
Kerala is doing okay. I think we should. Yeah, it's already 11.
Madam, you have the password, no?
Has Dr. Rupak joined?
Okay. Okay. I'll yeah. So we'll start. Madam wants a direct link, so she will join by the time Karthik can start.
Sure.
Okay. So,
Can I share? Or
Karthik, Dr. Preetham will introduce the CME and then you can start.
is Dr. Rupak here?
He's joining. He's joining.
Okay. So, good morning, friends. Good morning to all the BOA members to another edition of our online iPlugged Talks webinars, which we've been conducting since the Corona pandemic. The topic we've chosen today is essentially on imaging, retinal imaging. We all know the importance of retinal imaging. We all know how retinal imaging has changed the way we look at certain diseases, how we follow up these diseases. We all know the kind of technological advances which have happened in retinal imaging. You know, from invasive imaging, we have gone to non-invasive imaging and so on. We have with us today really eminent faculty, not just our own, but from all over the country to, give us a lot of insights into various aspects of retinal imaging. So I've been given the pleasant task of introducing our eminent speakers. We have with us none other than Dr. Moona Bhende, madam. Welcome, ma'am. Madam has just joined. I think she needs no introduction. Dr. Moona Bhende is a senior consultant and deputy director at the Vitreoretina Services of Shankar Nethralaya. I can say that she is a teacher. She has been a teacher and mentor to many generations of vitreoretinal surgeons across India and abroad. And I can pleasantly boast to be one of them. She has authored the Shankar Nethralaya Atlas of Fundus Fluorescein Angiography. And her talk for today is OCT in inherited retinal disorders. We have with us Dr. Nishikant Borse, our own member, BOA member. Dr. Nishikant Borse is retinal surgeon and director of Insight Eye Clinic at Dadar in Mumbai. His formal training, vitreoretinal training, has been from Shankar Nethralaya. I can tell you that he's a par excellent retinal surgeon, and a testimony to that is his famous, world famous video on central retinal artery occlusion. I think that has been mentioned at various platforms, and that video has got him many awards, multitude of awards. Welcome, Dr. Nishikant, and Dr. Nishikant is going to speak. His topic for today is patients as partners. Then we have Dr. Unni Krishnan. Dr. Unni Krishnan is Medical Director and Senior Consultant Vitreoretina Services at Chaitanya Eye Hospital in Trivandrum, Kerala. He has been a fellow of Shankar Nethralaya. He has been, I've had the fortunate, I've been fortunate to, he was my colleague when I was at Shankar Nethralaya. And he has also taken some formal vitreoretina training from Sydney Eye Hospital in Australia. His keen interest in retinal imaging has transformed into an annual event that he hosts by the name of RIC, or Retinal Imaging Congress, which just in its 4th edition has become immensely popular all over India and worldwide. His topic for today is very important, that is OCTA OCT angiography, evolving terminologies and clinical examples. The other two speakers, Dr. Karthik and Dr. Rupak, Swapnesh is going to introduce them. Swapnesh, over to you to introduce our other two speakers.
Yeah, the other two speakers are the young guns of Indian retinal map. Dr. Karthik Meda is a vitreoretinal surgeon at Karthik Nethralaya. He is a gold medalist at his DNB exams, and he has been a co-fellow at Shankar Nethralaya VR fellowship along with me. And he has a tough job to present in front of his mentor, Dr. MPB Madam. And Karthik is a very, he always had very good documentation of all his cases, and he's a very good speaker. So thank you, Karthik, for taking this acceptance of presenting OCTA principles for all of us. I will introduce Rupak when he joins in. And over to Karthik, you can start your presentation with Dr. Preetham sir's permission.
Yeah, please go ahead. I think Dr. Karthik is going to open the innings. Please go ahead.
Yeah. Thank you, Swapnesh, and thanks to BOA for this opportunity. I'll be sharing my screen now.
Just one, a suggestion to all the people who are watching this, that on YouTube, you can post in your questions. You can type your questions on the YouTube chat. We'll take up those questions at the end of all the talks.
Your screen is visible, Karthik.
Right, great. So good morning, everyone. So I'll be talking to you on OCT angiography, the principles for newest technology. I have no financial interest in any of the models that are currently available. My exposure to OCTA has been relatively brief, with experience with the NIDEX systems and the OptoView systems. And this is a brief review of the current literature that is available. So as all of us know, OCTA angiography is a system to visualize the retinal and choroidal vascularization in 3-dimensional. And the main advantage being that it doesn't need any contrast agent to be injected. So it uses the principle of motion contrast to detect the blood flow within the retinal and choroidal vessels. We have all tried comparing the OCTA with the FA, the standard traditional FA and ICG. Where it has an advantage of being dieless. It can be repeated any number of times within a short period of short span of time. It gives a greater detail of capillary plexus, and it also has the advantage of segmentation. So that lets us have a look at the vasculature at various levels of the retina and choroid. Like any other modality, it has some limitations. One main limitation being that the leakage patterns are not visible, unlike the FA and ICG. Apart from leakage patterns not being visible. So this is in a single slide how OCTA works. So basically what it does is it takes a sequence of A scans in each of the B scan, and the B scan is run in the same region multiple times. So usually from technology to technology or company to company, it varies from 2 to 4 times, and it creates this array of B scans. And each of the region is compared for a motion change, what they also call as decorrelation. Decorrelation is basically anything that is not correlating between the B scans, and it creates a flow pattern. And all of them are constructed into a 3D cube. And then the 3D cube is subjected to segmentation through an NFAS method. So this is how a normal scan would look. On the top is the vitreoretinal interface, which is avascular. So we hardly see any vessel, we hardly see anything in that. And then there is the superficial capillaries, the deep capillaries. The outer retina is again avascular. Then we see, have a look at the choriocapillaries and the choroidal layers. So we can segment each of the layers, which is not possible with an FA, but the OCTA has an advantage in this. This image, the other image on the right is the OCT B scan, which is actually highlighting the regions of flow. Now, the segmentation is not uniform across all the platforms. So if we take different platforms, the segmentation is a little varied. So on the left side of the screen is the superficial capillary plexus, which looks a little different in each of the technology or each of the company platforms that are available. This basically is different because the zones that are used to segment varies between the companies, and also the technology that they use is a little different from each other. Now, like any other new technology that comes in, there is always a challenge. So the challenge with OCTA was that there was variations in acquisition processes, which had to be refined and improved over the traditional OCT. There was changes in the processing, requiring better hardware for processing a lot more data than what we receive in OCT. There were newer algorithms that had to be constructed to compare between the OCT and also to counter the defects that appear in the image processing, and also artifact elimination in the results platform. So in OCTA compared to OCT, there was a requirement to increase the scanning speed tremendously. In OCT, speed between 25 and 50,000 A scans per second was more than sufficient for us to do a decent OCT image. But in OCTA, since there needs to be a repetition of the scan to be done in the same region, the A scans have to be increased. So most of the current platforms range from about 70,000 A scans to the current ones, the latest ones, to about 120,000 A scans per second. The next major hurdle that OCTA had to overcome is the motion. So as we know that the OCT has a higher resolution in the axially. So whenever there is a subtle movement in the retinal focus, either axially or in the transverse, it can lead to a higher abnormal decorrelation between the B-scan images. So this causes artifacts. So this had to be taken care of. So some of the reasons why there were axial motion is because of the normal pulsation or the cardiac cycles, and the transverse motion is obviously because of saccades and refixation done by the patient. So in the axial motion, so this is an example where the axial motion has not been corrected. We can all see that there is a fine sinusoidal wave. So that is created by every pulsation of the orbital pulsation, causing the entire retina, entire eye to move forward and backward. And that has been corrected with many algorithms. One of them is the split spectrum amplitude decorrelation algorithm, where all the B scans that have been received are converted into low resolution amplitude frames. Now, these images are subjected to decorrelation, and only the regions where there is a change between the B scans is picked up, and then they are averaged, to receive a better picture. Now, to correct and apart from this, there are other algorithms which are taken up by the multiple technologies that are currently available. Now, apart from this, there was also the transverse motion that had to be corrected. So there were two ways that they tried addressing this. One was the software based, and the other was the hardware based. So in the software based, what they did was they took multiple scans, once in the x-axis and the other in the vertical axis, the y-axis. And then they correlated each of the scans, each of the A scans between the axes to compare them and to correct for the motion artifact or the transverse motion artifact caused by the patient's eye movements. But even in this, there could be some artifacts which we develop, like there can be a reduplication of the bezels that are seen here, or they can have the stretch artifacts which are visible in this center picture, or they can have this block kind of artifacts which come in. So apart from this, most of the other equipments use the retinal eye tracking system, where the eye movements are sampled up to 15 times per second. And if there is an eye movement till the eye resumes fixation, the scanning is paused and then again restarted once the fixation stabilizes. So there are multiple names that the companies have given to correct for these motion artifacts. Now, once the data has been received from the scanning protocols, they are subjected to a number of algorithms. Now, each of these companies have their own system of developing algorithms. One of the better ones is supposed to be the OMAG algorithm, which is developed by the Zeiss angioplex system, which looks into both the phase and the intensity variation between the scans that are available. SwapSource OCTA is also there, has the advantage of having a longer wavelength, hence better penetration. But since the wavelength is longer, there is a small reduction in the resolution when compared to the standard OCT, the spectral OCT OCTAs. So there are again the two ways that the OCTA detects. So one is called as the phase variance. So whenever the low coherence light is reflected off the red blood cells, there can be a change in the frequency at which the waves return back to the sensor. Now this is captured and termed as phase variance. So this is one way that the system or the algorithm picks up movement. The other algorithm depends upon the intensity. So it depends upon how intense the light is getting reflected off the red blood cells. And there has been literature which says that the phase variance algorithms are slightly better than the intensity variance algorithms in picking up signals through the OCTA. Now, one other thing that they had to take care of is the projection artifacts. Now, what exactly is projection artifacts and how does it differ from shadowing? Now, whenever light falls on a surface, it can get transmitted, it can get reflected, and it can get refracted. So the retinal tissue is not an opaque tissue, it is transparent between layers or translucent between layers. So whenever there is light that is falling on the red blood cells, some of the light passes deeper or gets refracted and falls on the retinal pigment epithelium. Now the RPE is a very high reflective layer. So whatever light that falls on the RPE can get reflected back, and that can be picked up as a projection artifact, which is not exactly there at that particular layer. This was a nice experiment that was done by by one of the groups, which demonstrates that the projection artifact, simply there is a slide on which there is a small amount of water and there is light falling. And here we can see that the movement is picked up on both the places. It's picked up at the level of the slide and it's also picked up at the basal layer. So this is a projection artifact. So the similar thing happens in the OCTA of a normal OCTA of the eye. So this is the superficial capillary plexus, and this is the deep capillary plexus of the macula. And we can see that the superficial capillary plexus are also reflecting on the deep capillary plexus. So this is a projection artifact. Now this has been corrected using again algorithms where simply this image is subtracted from the deep capillary plexus to reveal the actual deep capillary plexus in the retina. Apart from that, we can also see this the artifact happening at Drusens, where the capillary plexus reflects on the surface of the Drusen, giving the sense of a pseudo vasculature on the surface, or sometimes there is shadowing at the base of the Drusens. Now, there are some other limitations, some more limitations of OCTA in terms of imaging under low signal strength. So we always know that when the signal strength is good, the noise is low. But when there is poor signal strength, the noise is high. Now, OCTA depends upon a good signal for it to pick up movement or pick up motion contrast. So when the signal strength drops, either because of shadowing, poor media, or deeper layer, then it can lead to poorer resolution of the images. This again, it also becomes difficult to image the choroidal vessels because the light doesn't penetrate significantly beyond the RPE choriocapillary layer. The other limitations can be slow blood flow, which can happen. So in these two images that are visible, the one on the left is showing, these are diabetic eyes. The one on the left is showing, the one on the left is showing microaneurysms at the edge of the face. But in an immediate sequence, these microaneurysms tend to disappear. Now, this is because of a slow flow where the OCTA is able to image the flow over here, but suddenly once the flow reduces, the OCTA is not able to image in this frame. The other issue with OCTA is that the flow speeds are not related to the image brightness. So if you look at this image, all the vessels, irrespective of the speed of flow of blood within them, have equal or iso intensity. So this is one other issue which they are trying to sort out. So the intensity does not vary upon the brightness of the image. Yeah. So now there is the concept of quantitative OCTA that is coming up, which uses a newer technology called as the variable interscan time analysis algorithms. So what they do is that they color code the flow patterns. So anything that's flowing fast is given red colors, which is seen in this, and anything that is flowing slow is given the blue colors. So with this, we can also get not only the perfusion status of the retina, but also get to know as to what is the speed of the circulation that is happening. So the top images are the capillary plexus, and the lower images of the choroidal plexus, choroidal capillary plexus, which is showing a much higher flow where compared to the retinal circulation. So to conclude, OCTA is a newer modality which has a definitive advantage of it being non-invasive. It gives us volumetric scans with the help of segmentation, which was not available with FA. Since there is no dye use, it can be repeated at frequent intervals on every patient's visit and reduces the risk of an anaphylactic reaction or the untoward events. It is quick. It provides an accurate size and localization information, and it helps in visualizing both the retinal and to a certain extent the choroidal vasculature. It can be used in most of the common ophthalmic retinal conditions like AMD, diabetic retinopathy, retinal vein and arterial occlusions, and also has a role in glaucoma diagnostics. However, there are limitations which are currently being overcome and worked upon. There are smaller zones which have now improved with the help of larger scan size and also with montaging, auto montaging of the OCTA films that are available. Artifact elimination was a challenge which has been significantly refined with the current modalities that are available. And the inability to detect slow flow is still a problem, which impedes diagnosis of especially deeper choroidal vasculature problems like IPCV or other entities. So these are some of my references, and I thank you for this opportunity again.
Thank you, Karthik. Can you stop your, Thank you so much. So as usual, a very lucid presentation by Dr. Karthik. Karthik, one just question, how to get around projection artifacts? Means obviously we are going to face it. And if how to overcome that particular problem? Is there any way before giving a clinical judgment while reading a octa signal? What are the things that you are trying to see?
See, projection artifacts are there are automatic algorithms in the software itself which corrects for some of the projection artifacts. But when we are looking at pathology, tissue with pathology, and when we are looking at segmentation, some of the times we may have to read the vasculature based upon the projection artifacts it is creating. So if we are looking at, say, a fibrovascular PED, then we may have to look at the projection artifact of it on the base of the Drusen, which helps us in the diagnosis. So I think manual segmentation in these instances is the key to also look at and understanding the artifacts or differentiating artifacts from the actualities.
Yeah. So in a simple words, manual segmentation is one thing. We have to have a structure flow correlation, as well as we have to always still look at the structural OCT, the basic OCT, before commenting anything upon the octa signals.
True. Yeah.
Yeah. And then one point just I wanted to add about microaneurysms. Yes, they are low flow lesions, but sometimes if the wall of the microaneurysms is hyalinized, even then the octa signal is very low. True. And I would request an opinion of the seniors whether this statement holds true, that if there is a no signal on octa, does that mean that there is no flow at all, or it might be other way around also, that if there is no signal, it doesn't mean that there is no flow, there can be some flow. Is it true in all cases? So Dr. MPV madam or Dr. Unni or Dr. Preetham can answer. So
So I'm on. Yeah, I'll just take this small. So basically, microaneurysms were thought to be the trademark lesion to show the limitations of octa, which means that in octa you have a threshold of flow. And threshold of flow depends on a lot of things, especially something called the interscan time. The time it takes for the scan to go and then come back to normal and rescan. So in a microaneurysm, you could have, it is not that microaneurysms do not come up on octa. So that is what we have to get clear. Microaneurysms do come up on octa, but there are microaneurysms that do not come up on octa. That is one because of the flow is very low. Now, a lot of other lesions inside the eye, like cystoid macular edema, the wall of the cyst, can cause enough reflection so that the OCTA doesn't become microaneurysms also. So that is why it is typically said that you see more microaneurysms on FA than on octa. However, there are some wonderful papers saying that the octas that the microaneurysms that you pick up on octas are the only ones you need to treat, because they have a sufficient amount of pressure inside and flow inside. It's a good paper that's coming, is doing the rounds now. So that's a very interesting concept about microaneurysms and OCTA.
So, Preetham sir, any comments, or should we move on to the next topic? So you're muted.
No, I agree with what Dr. Unni said. So I think we'll move on to the next topic. We'll be having a lot of questions and queries at the end also.
Yeah. Dr. Munna madam. Yeah, madam, can you share your slide? Your slide is visible, but we can't hear you.
You have to unmute me.
You are unmuted. Yeah, now we can hear you.
Okay, because
Okay.
I couldn't. Yeah, is okay now?
Absolutely fine.
Fine. Good morning, everyone, and thank you, Preetham and Swapnesh, for inviting me. This topic is a little bit out of the general theme of the meeting, so please bear with me. So my talk is imaging in inherited retinal disorders. Can OCT make a difference? I'll start with the case of a 7-year-old girl whom I saw finally just last week. She was recently diagnosed to have high myopia. She had a little squint, but despite glass correction and review every 6 months, her vision was not improving beyond 618 N6. She had no other visual complaints. She had a retina opinion after a year, which they said it was just high myopia and the ERG was subnormal, possibly due to myopia. 18 months from the first visit, she had been advised OCT for possible macular pathology that could account for the poor vision, but the OCT was normal. You see, these are the printouts. And this was a fundus picture, which just showed high myopia and no obvious macular changes. The shiny reflex is just that of the young retina. Now, 10 months later, when I saw her, she had the same symptoms and the same findings. Vision was not going beyond 618 N6 in both eyes, and the ERG was subnormal. And this was exactly the same as the 6 months earlier. These were her dark and light adapted ERGs. I asked at this point for a wide field fundus image, and you see the optos. It shows the myopic fundus. It shows peripheral areas of lattice degeneration. What I'd like you to see is a very subtle alteration in the color of the retina between the arcades and the mid-periphery, and also some small areas of chorioretinal atrophy in the periphery. The autofluorescence image also shows a change in autofluorescence within the arcades and beyond. And a similar thing was seen in the left eye. So thinking that sometimes patients do have a dome-shaped macula in high myopia, which prevents them from getting corrected completely, we asked for a wide field OCT along with a crossover autofluorescence image, something that's available on the Heidelberg. And if you look at the autofluorescence image, it shows this sharp rim of change in autofluorescence just at the arcades, the same point that was showing the change in fundus color. And if you look at the OCT picture, you see beyond the macular region, there is an abrupt change of the photoreceptor reflectivity. The ellipsoid zone suddenly tapers off at this point, exactly correlating with the change in autofluorescence. So this gave us a clue that there may be something else other than just high myopia. We advised her visual fields, but being a 7-year-old child, there were a lot of high positive errors, so the fields were not very reliable. We have now suggested examination of immediate family and also gene testing possibly once we have examined the other family members. So why OCT in inherited retinal disorders? We usually ask for ERG because we know OCT is able to identify the retinal layers, especially the outer retinal bands that are affected in almost all the dystrophies. We are able to see the external limiting membrane, the ellipsoid zone, and the interdigitation zone with the new systems, and these represent the photoreceptor layers. And we also know that within 20 degrees of the fovea, you are able to see a peak of both the rods and cones within this area, and this area is very easily visible on OCT. So OCT definitely has a role in inherited retinal disorders. And these dystrophies can involve the macula sparing the periphery, they can involve the periphery sparing the macula, or they can involve both. The commonest probably dystrophy where one would ask for an OCT is when you think there is cystoid macular edema of unknown cause, as in a patient with foveal schisis. The patient is typically young and has a visual acuity of about 618 in both eyes, not correctable further. But the OCT here tells you that though the clinical, you see the red free, I've put it for better contrast. It looks like bilateral CME. If you look carefully at the OCT, you see there are large cysts at the macula, but this typical pillar-like structures throughout involving both the inner and the outer layers that tell you that this patient does not have cystoid macular edema, but foveal schisis. Now, this is a 43-year-old lady who was on treatment for a seizure disorder. She had undergone LASIK for myopia and complained of blurred vision in both eyes. This was many years later. The referring ophthalmologist had diagnosed cystoid macular edema in both eyes, but the accompanying angiogram printout did not show any leak. She had a myopic fundus with cystoid spaces at the fovea in both eyes. And you see this OCT. I have used a wide field OCT, which shows that large cysts at the macula with a little pillar-like appearance on either side. The ERG had an electronegative waveform, and the LM and S cones were normal. We put her on topical dorzolamide drops, and over an 18-month period, you see that the cysts gradually reduced. Vision improved to 618 N6 with +3 ads. Subsequently, she developed cataract, has undergone cataract surgery, and now has a vision of 6.9 and 6.12. A 10-year-old male who came to us with problems with dim illumination. This is the picture of the right eye. Both eyes had a similar appearance. You see there are cystoid spaces at the fovea. You see the magnified image on the right. Cystoid spaces of the fovea. It appears that he has fluid at the macula, but what is more typical are these whitish deposits just beyond the arcade. The retinal vessels are normal. His ERG was fairly typical. You see the photopic and scotopic waveforms looking almost similar, and this gives you a clue to the enhanced S-cone syndrome. And this was his subsequent ERG with the LNM cones subnormal, and you see the enhanced response from the S cones. So this patient was later on genetically confirmed to have an enhanced S cone syndrome. The wide field OCT was even more informative. Here you see the paracentral chytic areas, and you see that the thickness of the retina slowly tapers off towards the arcades, which is very typical of the enhanced S-cone syndrome, seen even better in these pictures, where you have the vertical and the horizontal scans showing that the thickening of the retina is seen only within the arcades. Another condition where OCT is useful is retinitis pigmentosa. And why OCT? Because you can see the photoreceptor layer tapers off abruptly, and this is a structural marker for the edge of the visual field. If you look at this OCT picture here, I hope you can see my pointer. You see a abrupt loss of photoreceptor layer just tapering off, indicating that only a small area of central visual field is intact. And you also see that the choroid is thin. Now in RP, the main changes are in the outer layers. Outer nuclear layer thinning secondary to photoreceptor damage can occur more prominently in older patients. The inner retinal layer changes are variable. You can get thinning in advanced disease, but sometimes thickening due to remodeling in areas of outer nuclear layer loss. And in most cases, like I said, the inner layers are structurally intact. One may get a few hyperreflective foci, and choriocapillaries atrophy and pigment epithelial loss, secondary to photoreceptor layer loss, are responsible for poor vision. This is a nice study which shows you the structural changes that occur over a period of time. And if you follow this sketch on the right side, you see that the area of viable photoreceptors gradually reduces over a period from 2011 to 2013. And this change in appearance is also reflected on the autofluorescence image. So comparing the autofluorescence image with the OCT, you have the following clues. Where the external limiting membrane is intact, you have normal autofluorescence. Where the ellipsoid zone is lost, you have hyperautofluorescence. And when the interdigitation zone is lost, you have loss of autofluorescence. And the sequence of events is loss of interdigitation zone, loss of ellipsoid zone, and loss of external limiting membrane. And this can be very well picked up on a high resolution OCT and used to follow the patient over time. So this is now a very integral part of our follow-up of patients with hereditary disorders. The other changes, of course, are cystoid macular edema that can occur due to damage due to retinal atrophy and destruction of retinal layers, and typically a non-leaking cystoid macular edema. You can also get epiretinal membranes and vitromacular traction. This interesting paper in ophthalmic genetics showed that you could get changes in retinal structure on OCT depending on the genotype. We know that Leber's congenital amaurosis has a large number of genotypes, and each genotype appears to have a fairly typical retinal structure. You can have the retinal structure normal, you can have it thicker, or you can have it atrophic, and these are the various genotypes which present with different pictures. Now, this is a 14-year-old male who had poor vision since early childhood, more in sunlight. He had been put on steroids on and off, and he even had an injection Avastin in the left eye for subretinal fluid, and subsequently was put on low vision aids. His best corrected vision was 645 N6 and 660 N8, and his color vision, which gave you the hint, is 2/21 in both eyes. The fundus looked almost normal, except if you look carefully, a small area of dark patch at the fovea. But if you see the OCT, and this is just a normal OCT, shows that there is loss of the photoreceptor layers, loss of the cost line, showing a well-defined area of hyporeflectivity right under the fovea. You see the cone responses are absent on ERG, and this is very typical of achromatopsia. This is not subretinal fluid. This is just a hypospace because of loss of photoreceptors in these layers. And these form a particular staging. So in the early stages of achromatopsia, you may not see many changes except for small hyperreflectivity of the external limiting membrane, whereas progressive loss is seen as a more obvious optically empty space as you move from stage 2 to stage 4 till you reach the advanced stage of complete retinal pigment epithelial disruption with loss of the outer nuclear layer and the typical bullseye pattern on the OCT. This is another patient showing a very prominent hypospace at the fovea. And this is a patient where the hypospace is more in a ring-like pattern around the fovea. Both these patients have achromatopsia. Stargardt's dystrophy is probably the most common macular dystrophy we come across and has fairly typical clinical features. And very often we are able to diagnose Stargardt's dystrophy without any investigation. However, because we have newer treatment modalities coming up, one would always need to confirm your diagnosis with additional investigations. And the features you would see on Stargardt's dystrophy is a central retinal atrophy, as you see in all the images on your left. The primary change is in the pigment epithelium and Bruch's membrane complex. And the changes in the photoreceptors are secondary, as this is primary and RP pathology. And these secondary changes are loss of the ellipsoid zone, thickening of the external limiting membrane, thickening of internal limiting membrane, and thinning of the outer nuclear layer. And sometimes you can get hyperreflective deposits anterior to the pigment epithelium traversing the photoreceptor layer, as you see in the last picture, where you see them right under the fovea. And these changes on OCT correlate well. The correlation between the photoreceptor layer integrity seen on OCT correlates well with visual function in patients with Stargardt's, and thereby this can have implications for gene therapy. And we all know Stargardt's can extend even beyond the macula. As you see in this patient who was initially diagnosed to have retinitis pigmentosa with macular atrophy. This is the OCT image showing loss of the photoreceptor layer and retinal pigment epithelium at the fovea and hyperreflective deposits here. And you see that the changes go far beyond just the foveal region. This is a fairly dramatic picture and I couldn't resist sharing it. You have these bright, highly reflective drusen in a radiating pattern coming from the fovea in a patient who is too young to be having a. This patient can have drusen, this patient can have choroidal neovascular membranes. And this typical picture of large drusen radiating from the macula, some of them showing hyperautofluorescence on the autofluorescence image, is very typical of the honeycomb retinal dystrophy, autosomal dominant Drusen, more popularly known as Malattia Leventinese. And the OCT picture is very dramatic, very typical. You see these drusen and you see a diffuse thickening of the RP Brooks membrane complex within which you see these drusenoid elevations. This patient had subretinal fluid and a shaggy photoreceptor layer as well. So this OCT picture is very typical of Malattia Leventinese. This was a young child who was on treatment for suspected toxoplasmosis in both eyes and then subsequently considered to have choroiditis. You see the clinical picture, you see foveal scars in both eyes, but what is more dramatic are these vitelliform deposits around the arcades. Now you see there are no vitelliform deposits at the fovea, they're only around the arcades. In both eyes, fairly symmetrical. The OCT shows this fibrotic lesion at the fovea, but what is very typical is the thickened photoreceptor layer in both eyes, something that is seen better in this picture. This is what we call the Verhoef's membrane. You see it well in the wide field OCT, but you can see it in any OCT. This is the Verhoef's membrane, which is a very classic feature of Best's vitelliform dystrophy. The autosomal recessive form in this patient, where you have vitelliform deposits around the arcades and not at the fovea, and these fade with time. You see this patient over a 7-year period now is left with only foveal scars and some pigment epithelial changes. The autofluorescence picture is characteristic, and the OCT typically shows fluctuating subretinal fluid that comes and goes irrespective of whether you treat the patient or not, and very few secondary changes in the inner retinal layers. This is another variant of Best dystrophy, the adult onset form, where you may just have a small yellow spot in the fovea and the patient presenting with distorted vision. The OCT shows this typical small pigment epithelial elevation right under the fovea, and the EOG is diagnostic, where you can have a subnormal EOG. Now one may see this picture of extreme geographic atrophy in a patient who's just about 60. And this is a time when you need to think otherwise. A 60-year-old patient is unlikely to have this much of age-related macular degeneration. Look carefully at the fundus photograph. You see atrophy at the macula surrounded by these yellow spots that can be easily mistaken for drusen. The autofluorescence image shows loss of RP and choriocapillaries. You see the large choroidal vessels are seen, a little bit of sparing of the fovea in the right eye. And you see the OCT shows extreme thinning of the choroid, indicating that this is a choroidal dystrophy. What is typical? There is loss of RP and photoreceptor layer here, but something very typical of these choroidal dystrophies is the presence of outer retinal tubulations, which indicate areas of surviving photoreceptors. So a thin choroid, loss of RP and choriocapillaries layer, and presence of outer retinal tubulations is very typical of the choroidal dystrophies. This is a more extreme form. This patient had both eyes scar at the macula. You see the crystals in the retina in the mid-periphery. There's loss of RP choriocapillaries at the posterior pole. And the OCT shows these intraretinal crystals very nicely. Sometimes changes may not be very obvious. The patient may just have poor vision, and the wide field photographs do help us to see that there is something abnormal. You see the Oguchi's reflects the golden sheen that is there in the macula. The patient has poor vision and photophobia. The autofluorescence image does not show much because the vitreous floaters right over the macula. But the OCT shows that there is loss of photoreceptor layer at the fovea, which is typical of cone dystrophy, whereas in retinitis pigmentosa, the central area photoreceptors are spared, whereas in cone dystrophy, you see in the lower image, there is loss of the photoreceptor layer right at the fovea. This is the patient's ERG and multifocal ERG as well. And retinitis pigmentosa can also have macular involvement, as in this patient, very little pigment, but macular atrophy as well. And these are the OCT images showing hyperreflective deposits just over the Brooks membrane and extreme loss of RP and photoreceptor layer at the macula. Again, another patient with cone dystrophy showing macular atrophy. And this is seen at the posterior pole. And you see a small area of surviving photoreceptors in the center showing a little peak on the multifocal ERG. Now, this is a picture if a middle-aged male comes and sees you with a lot of depigmented retina, a few bone spicules, and a central area of what appears to be dark but is actually normal retina. And the OCT here is very dramatic. You see the central area looks quite normal. This very small central area looks normal, beyond which there's an abrupt loss of the choroid. And you see that in all the pictures. And at the border, if you look at the slide images on your right, just at the transition zone between normal and abnormal retina, you see these outer retinal tubulations. So this extreme cutoff, very dramatic transition zone with choroidal thinning and outer retinal tubulations is very typical of choroideremia, especially in the advanced stage. And this was the ERG and visual fields of this gentleman. He was genetically also confirmed to have the choroideremia gene. Now, choroidal imaging is the new flavor for OCT imaging, but may not be of very much use except in certain situations in inherited retinal dystrophies, basically because choroidal thickness is reduced in almost all forms. In Best dystrophy, the choroidal thickness varies depending on the stage. In the earlier stages, the choroid may be normal. It may be thicker in the vitelliform stage and becomes thinner in the atrophic stage. And the choroidal vascularity index, as of today, seems to be reduced in all forms of inherited retinal dystrophies. So my last slide to conclude, OCT in inherited retinal dystrophies is important. In primary photoreceptor dystrophies, you get changes in the photoreceptor layer with secondary involvement of the pigment epithelium and choroid. And the inner retina retains its structure in most cases. And the loss of layers is seen in a more gradual manner, as I showed you. Whereas in primary choroid or RP dystrophies, there are inner retinal changes due to RP disruption. You get outer retinal tubulations, and the transition zone is quite dramatic, as you saw in the patient with choroideremia. There are characteristic features for specific conditions, and definitely the use of enhanced depth imaging, wide field OCT, sequential OCTs, and ANFAS images help improve our understanding of the disease and its progress. Choroidal imaging is there, but maybe not specific as of now. And we definitely use OCTA now to identify choroidal neovascular membranes. Thank you very much for your patient listening.
Thank you, Dr. Moona. That was quite a lucid and extensive presentation on importance of OCT in inherited retinal disorders. While we take some have a discussion, I would request who's the next speaker, Dr. Swapnesh?
Dr. Unni.
Dr. Unni, you could start sharing your video, while we initiate some discussion. So, Dr. Moona, I would like to ask you, can you unmute Dr. Moona, please, Swapnesh?
Just a minute.
And you could unmute Dr. Unni also. Yeah, we are able to see your slides, Dr. Unni.
Yeah.
So probably you can have just one question I would like to ask Dr. Moona Bende. Madam, as a routine, would you suggest that in inherited retinal disorders, OCT should become like a routine part of our checkup?
Yeah, I think so. I think so, Preetam, because we are doing it now as part of our evaluation. And we do an enhanced depth OCT because it's a little more informative.
Okay.
If you have access to wide field, definitely. You need not always have the swept source image. A lot of other machines also give you almost a 55-degree view. And autofluorescence imaging as well, because we know that assessing prognosis and progress of the disease is much better.
Okay.
But just a regular OCT probably may not give us much information. That's why I showed the first case, because it may be quite misleading.
Right. Okay. Thank you. Madam, we'll have some more questions at the end. So I'm going to ask Dr. Unni to start, and he's going to speak on OCT angiography in age-related macular degeneration. And he's going to tell us about the new terminologies and newer thoughts, because, you know, we are so used to now the normal OCT terminologies, but with OCTA, you know, there are some new things which are which we have to start looking for. So Dr. Unni, it's all over to you.
Thank you, Dr. Swapnesh and Dr. Preetham, for the invitation. And we'll be starting on, I tweaked it a little bit to talk about AMD because there's a lot to concentrate on AMD rather than the whole gamut of diseases. Okay. Okay. So why do we need an OCT in AMD? So I put the word diagnosis there. So we'll just keep it at that, and then the newer thoughts will explain why we actually need an OCT angiography in AMD. So for the new fashion around in terminology is that instead of calling them CNVMs, they're called MNVs. That is, we call them type 1, type 2, and type 3 MNVs. It's just the same. A type 1 MNV is underneath the RP and between the groups, typically characterized by fibrovascular PEDs. A type 2 MNV is equivalent of the type 2 CNVM. It's a pre-RP CNVM in the vascular zone of the retina, and then characterized by the presence of a lot of subretinal and intraretinal fluid. And then you have your type 3 MNV or macular neovascularization, which is the previously called the RIP or proliferative retinal anastomosis. So I'll start with the type 2 pattern. What we typically look at in a type 2 pattern rather than type 1. The type 2 pattern of the classic membrane. So what you see is a type 2 membrane with the OCTA. So typically described as a lacy, fine, intricate pattern. I would like to add these two terminologies, two characteristics, that is, you hardly see the gaps. So if you have a very dense membrane where you hardly see the gaps in the membrane, that's likely to be a type 2 membrane. And then you can see a very distinct outline. So this is, in this you see the very distinct outline, hardly see the gaps, lacy, fine lacy pattern, and this is how a type 2 appears on an OCTA or an OCT angiography. We'll just go through different examples here. Clinically, you can easily make out the membrane over here. And then when you do the angiography, you nearly see the same pattern very closely knit. You see the outline pretty much well. And again, by the principles, you see the outline, point number one, you see a very dense lacy pattern of blood vessels, and that's how you make out a type 2 macular neovascular membrane. So one of the things is that you need to know about the structure flow correlation. And this is a very classic example. These are the flow details converted to the V-scan. And here you see inside the lesion, you see flow characteristics which have been picked out as yellow. This is a Heidelberg system. And this is, even when you remove the OCT image, you see the flow characteristics over there. So this is how you know that there's an RP breach, and it is above the RP, and the flow, there is flow above the RP, hence diagnosing a type 2 macular neovascular membrane. This is another image of the structure flow correlation. Here you can see the fusiform appearance of the CNVM, and in those you see all these small yellow dots which represent that there is a particular flow happening above the RP level over here. This is the RP level. There's flow above the RP level, typical fusiform described as the OCT, and a type 2 membrane again. Again, this is another patient. We're just going through some clinical examples. Well-defined, can see a wonderful outline, can see the gaps in between. This is one way I like to diagnose type 2 membranes. Yet another patient you see with a very dense membrane over here, radiating on two sides, but you can see an outline. You don't see any intervening spaces in that. It's a good way of diagnosing type 2 vascular membrane. So this is a whole sequence of images that is a multicolor. The green shows a bit of elevation of the retina, which corresponds to fluid. And then you have the autofluorescence showing an area of blood fluid, probably hemorrhage. Subsequently, you have an infrared reflectance image. the OCT image showing sub SHRM or subarctic reflective hyper reflective material. And then you see on the octa, you see a membrane over there. So for diagnosis, is it good? Yes, obviously it is good for diagnosis, but that shouldn't be the only thing we use octa for. Another lesion over there, and this is how you can see how differently it appears on the angiography, the fluorescent angiography. You don't get great detail over here. On the classic membrane doesn't appear that well on an ICG, but on the octa, you see every nook and corner, every part of the membrane you see excellently clearly, and on the structure flow correlation, you see that there is flow above the level of the RP, diagnosing a type 2 membrane quite easily. So that's an enlarged image of the type 2 membrane. This is yet another patient where you see a membrane, but this is post-treatment. You can see this is pre-treatment and this is post-treatment. There's flattening of the retina, the lesion has gone away, and you don't see any membrane on the post-treatment area. This is interesting. It's a patient with SHRM. And what is interesting is that when you do an octa, you see the contributory membrane. So there is a terminology that has come out that is called vascularized SHRMs, in which you can make out the vascularity on the OCT angiography associated with the subretinal hyperreflective material. So we've done a diagnosis part of it, and I'd like to skip to this. Is a very important slide I keep showing. How do you get good octa images? First, you have to do essentially a quick screening using a very thin slab. You can go all over the retina using this thin slab, and you can find the lesion. Then you can increase the thickness of the segmentation of slab so you see the whole extent of the lesion. And then you can push this slab up and down the V-scan OCT so that you see the lesion in different depths. As Karthik said, this is a wonderful way of identifying whether a lesion is a projection artifact. If you see the same lesion at higher levels and lower levels, saying you know it's a projection artifact. Then you have to correlate with the NFAS, and then you have to correlate with the structure flow correlation that I showed you previously. So that's how you acquire a good image. Qualitatively, I do not like to go for automated. You do your own manual segmentation often to find out how a lesion is. So this is something. So this is what I was saying. This is a very thin slab, and you make out the lesion there. The next slab, you thicken, you raise the lesion, and you see the lesion in a higher plane, not to the full extent. And then you thicken the slab, and then you see the lesion in its full entirety. So this is a macula. This is a type 1 membrane. You see the entirety by varying the thickness and the depth of the slab. See that again a bit more zoomed up. And in this is the same membrane in 3 different thicknesses and 3 different slab positions. You can see the membrane come up well. So some of these images are some from seminal articles about how to describe OCT patterns. So there was a beautiful paper which first described the Medusa pattern. The Medusa pattern of the membrane was one which started and radiated in all directions as you see here. So this was a Medusa pattern. This was a C-fan pattern. You had the C-fan, and then the membrane is on one side, preferentially on one side of the origin of the blood vessel. So that was called a C-fan pattern. And then there was also a glomerular shape pattern that was described where it is something like a C shape, but it's like a tuft originating from a circular coil of vessels. This was another very interesting description by another group which divided CNVMs or membranes into loose net membranes where you could see spaces between the membrane, or dense membranes, which I showed you earlier, which would be a very dense, hardly see the space in between membranes, and mixed type of membranes where you could get both patterns in one particular patient. This was a very brilliant article which divided the CNVM lesions into 2, a pattern 1 and a pattern 2. Pattern 1 essentially meant those requiring treatment, and pattern 2 means those which did not require treatment. So this is how it was defined based on the shape, the branching index or the number of branches, whether they were anastomotic loops, whether there was vessel termini or it had a dead T appearance, or whether there was a peri-lesional halo. If you had 3 out of 5 of these characteristics, it was called a pattern 1 which required treatment. If not, it was called a pattern 2. We'll come to this later, so I'm not going to stress on it now. So this was called a dense membrane with anastomotic lesion all around. This was a filamentous part with vessel termination, no anastomotic lesions. So these are the anastomotic channels that go around. And this is what you mean by a perilesional halo, an area of darkness around the lesion in which there's an absence of chorea capillaris, which is quite interesting when we think of the absence of chorea capillaris being one of the pathogenetic features causing local increase in anti-VEGF and therefore the growth of the membrane. Type 1 membranes were described in this paper to be, that is your type 1 aneurysmal or PCV, to be circular pattern, a cluster of polyps, discrete spots, or plainly just undetected on OCTA. So these were the three names: circle, cluster, spots, and undetected on OCTA were the how you describe an OCTA lesion of a PCV. Now we'll go to type 1 MNVs or your type 1 neovascularization. So you have a type 1 neovascularization all underneath the RP, and this is your typical pattern. You have coiled filamentous things with spaces in between and anastomotic lesions, attachments all through the edges of it. So this is a pretty typical looking type 1 MNV. So essentially the trunks are larger, they have branches. However, the branches are very limited. Around the edge of the lesion, you see all these anastomotic connections, and you have fine fibrillary attachments to the anastomotic connections, which probably are signs of activity. The dropout of the capillaries are what you see. The chorea capillaries are surrounding the lesions, what are termed as a dark perilesional halo. So we've gone through all of these. You can see some of the lesions. You have large, essentially, you have larger vessels. You have an anastomotic channel going around these vessels when the lesion is highly active, and you may have fine fibrillary vessels also. A type of type 1 MNV, which is always creates trouble, is the vascularized PAD. Why is it problematic? Because it's really difficult to get the segmentation lines and find out the lesions. But here you can see, you don't see any abnormal lesions. You just see problems because of different segmentations. You see the segmentation to the top gives you this, and the segmentation to the bottom gives you a huge lesion, but you don't see a vascular network. However, this is something which is quite interesting. Sometimes on NFAS, you see large vessels feeding the PED, and you can be pretty sure that the neovascularization is at this particular area. So when you take a segmentation, the large vessels will appear dark on the OCTA, but here you see a little bit of activity over here feeding the vascularized PED. So this is another one in which we've brought the segmentation way to the bottom of this. Again, very unsatisfactory information from within the PED, but here at the edge of the PED, you see the start of a vasculature just at the edge, and probably the vasculature of the PED starts somewhere over here. This is yet another lesion in which you can see vascularity of the PED starting at the edge of the PED, and you don't get much information from the center of the PED. So I'd just like to show you this particular patient. This is a clinical course of a type 1 over many, many years. So here you see what we say, you see the large vessels, filamentous vessels, some peripheral changes. The next slide, you see a little bit more of anastomotic changes here with a new lesion developing over there. And unlike the previous, you see an appearance of subretinal fluid. Over time, this particular lesion increases and there's persistence of the subretinal fluid despite treatment. This patient received many injections of anti-VEGF over time. And over time, you can see when it became flat, the whole lesional complex has gone away, but you still see some evidence of vasculature over there. So this is a typical a clinical course in a type 1 macular neovascular membrane. So PCV is now called type 1 aneurysmal. By some authors who like to push that particular name, we still love calling it PCV. So you have an FFA of a PCV and an ICG of a PCV where you see polyps. You see a faint outline of a vascularity over here. So that's your BBN with polyps on the left side, and the right side picture, on the left side picture, you have a FFA. But this is the beauty of your OCT angiography. Different cuts. One cut, you exactly see where the polyps are. Another cut, you beautifully see where the branching vascular network is. You correlate both of these. You can see the branching vascular network ends in the polyps, which is at a higher level than the branching vascular network. This is another beautiful picture of polyps which have come on the ICG angiography, and you see, in this particular picture, you see the branching vascular network lying a bit deep, not picked up that well, but you can see the polyps at the edge of the branching vascular network here and over here. Another lesion where you see a polypoidal lesion with the network and the polyps at the edges of the branching vascular network. You can quite nicely see it over here, a few polyps here, and that's how it is. So I can just show you these images. Okay. Now the type 3. The type 3 was in a wonderful study that showed that because the OCT angiography is depth resolved, you could pick up a type 3 technically better because you would have vascularity, vascular markings in the retinal layers, as well as you could see and trace the proliferation up to the choroidal layers also. So that's what a study by Mia showed that. I will just go into Mactel. So I'm just going to show you these images where Mactel, this is a non-proliferative Mactel where you see the vascular abnormalities in three particular, this is a proliferative Mactel. So I'm just showing you this. This is, you can see in the superficial vascular layers, you can see some changes over here. A deeper layer, you can see an abnormality, the intermediate layer and the deeper layers, you can see the abnormality increasing of the vascular changes in the temporal to the FAZ, and in the avascular layer you don't see much changes. This was a non-proliferative one, but we go to the next one, you see changes over here. Subsequent lesions, you can see some dropout, rarefaction, and some changes in the intermediate zone. The deep zone, you can see a lot of changes happening. And finally, you can see the vascular member, the avascular zone, which is supposed to be empty of any vascularity. You see a wonderful network, which is a CMM. So in a patient with Mactel, it's really helpful. The OCT angiography is a really helpful tool to diagnose the presence of a choroidal neovascular membrane. You see here, you don't know whether this is an old scar, a current scar, whether it's material. There's a total blooming that happens on the FA, but this is a point where the OCT angiography scores over the fundus fluorescent angiography because you can see the lesion wonderfully, picking out that it's a filamentous lesion. So the first thing I said was that, was it good for diagnosis? Yes, it was good for diagnosis, but that is not how we should ideally be using it. And this is how I think OCTA in AMD should be used. That is the newer thoughts. One, the presence of diagnosis of these three things, the non-exudative, looking at recurrence patterns. I'm going to bring a new term called recapitulation and something called scar assessment. So what is a non-exudative CNVM? Here you have a picture in which you see a slight elevation of the RP over here. There is no activity, but on the OCTA you see a small vascular network over here. So this picture is dated 2018, and skip forward 2019. That is about 6 months later, you see the presence of a membrane, but there's appearance of fluid. So this particular patient had a membrane without any exudation, which we call a non-exudative CNVM or a QMNV, that's a quiescent macular neovascularization. No signs of activity, but the presence of a net. Up to 22% or 25% become active over a period of a year. So it's important to diagnose these macular neovascular, quiescent macular neovascularization. Here you see another bumpy, elevated Drusen PED, and over there, really over there, you see this small piece of neovascular network with no activity. Another, you see a small lesion over there corresponding to a small tweak in the avascular complex. You see a small tweak of neovascular on the OCT angiography. That's what you see. Okay. So again, we're sharing the picture of a quiescent membrane. You can see in the structure, there's an elevation, but in the structure flow, you can see a bit of yellow going up into this elevated RPE, which corresponds to this particular membrane, which is very faint. So that's what the diagnosis comes as quiescent macular neovascularization. So there were concepts that it's such an early NV that has low flow, it has not started to exude or leak, and it's a predecessor of the CNVM, detectable only by OCTA, hence it's a new terminology, but it's very, very important to keep on watching these because nearly 20-22% become active in a year. So we'll just go to something called responsiveness. What happens to a lesion when you give anti-VEGF? So it's really interesting to know that the lesion becomes smaller, vessels, this whole area becomes smaller, vessel fragmentation. The larger vessels remain, but all the smaller vessels that you pick up on OCT go away. The flow becomes very uneven. This happens in the first 10 days. And the maximum effect is nearly about 12 to 15 to 16 days after anti-VEGF. After that, it starts increasing. That is, vessels start reproliferation. You get new anastomosis after the effect of the anti-VEGF goes down. The CNVMs get smaller and smaller, but denser and denser over time. So after each injection, this has been studied by the Lombroso group, in which the trunk reappears, has increased flow, but the vessels seem to be less, or the branching index seem to be less with subsequent injections. So this is what the Lombroso group said. A few pictorial representations and a few interesting images, how a medusa and how a sea fan look like. This is what we mean. We'll be showing you all of this. This is how an anastomotic channel runs through the edge of the vascular network, and a reappearance could mean early recurrence. Some of these lesions you can pick up feeder vessels. So this is a very interesting thing. So whether it is active or passive, that's the whole usefulness of this OCT angiography. It depends on the appearance, whether it's a lacy wheel or a C fan, or is it large and filamentous. Is the anastomosis, you have a rich anastomotic channel, or is it purely anastomotic? The branching, is it high index of branching index, or is you have only a few vessels? Do you have this vessel termination, which looks like a dead tree, or do you have something running all around? Which is more, if it does, it's more likely to be active. Do you have the particular lesion called perilesional halo, which is more suggestive of a chorioacupillary loss at the edge? So this is a few slides of a patient who was inactive for a long time. You can see there's rarefaction that keeps on appearing. There's no appearance of activity. There's no change in the lesion over a huge period. So nearly about 2 years or 2.5 years. There's no change in the lesion, and it has remained inactive for a very long time. This is another patient who was treated. You can see that after it became flat, you can see a single vessel over there, and it has remained, even though the vessel is more prominent, it has remained without developing any anastomosis, any additional branching over a long period of time. But recurrence is a rule in most CNVMs. And when you see this, by what I've told you, now you should be able to start seeing patterns of recurrence. That is, you see large vessels in the center, and you see smaller vascular terminations, anastomotic channels happening in the periphery. So when you see this, and this will probably predate your appearance of fluid or blood. So incorporating OCTA into management of a CNVM will be able to probably make you go away from pronto, that is PRN treatment. You can do your OCT and treat before fluid comes. Another blown up picture, you can see everything I've been talking about. You can see all this an anastomotic channel running around. You see smaller vessels hanging between the larger loops. You see smaller vessels hanging between the larger loops. And this is a person in which it has become reactive. Another patient, small vascular loops at the end. Connections, you can see this is like a frill of vessels in a previously quiescent, previously subsided membrane. This is a beautiful picture that shows both. You can see a large fibrillary pattern over here, large filamentous pattern, and at the edge you see a whole bunching out of new smaller vessels with this thing, and that corresponds to this particular area. It makes total sense. This is a scar which corresponds to this filamentous area, and this is where the activity has broken out, and this is how it looks like over there. So another picture, this is going just going to show, just please concentrate on this area. You can see an anastomotic channel running along that particular area of vasculature. So that's how it appears. This is another patient in which you see activity at the edges. All around you see an anastomotic channel, a lot of lacy pattern in this particular patient. Here again, this was a recurrence where you had only this vessel. This is a new formation and a reactivation in this particular patient. Again, you see this frill. So whenever you see frills running anastomotic channels all around, it could probably tell you that this patient is recurring and is still active. So this is blown up view. It's a beautiful picture over here. It's like just like a new blossoming of a flower that happens in a just opened up, something like that. Okay, this is quite interesting. This is a patient who was, you can just please look at this image over here. You can see an activity, large fibrillous loops. The next picture, this is a blown up picture of that. The next picture, you can see that after anti-VEGF, many of those areas have gone away. And then later you can see them reappearing in the periphery over here and over here. So probably it's very interesting to look at this and probably it could tell us about the presence of recurrence. This is a brand, not a new concept. It's a term that is getting thrown away everywhere, and it's a wonderful concept of recapitulation. What recapitulation means is that the essential pathology is you have a loss of choroidal circulation, chorea capillaris. This produces anti-VEGF. This drives the formation of CNVM, and then you treat the CNVM and you kill the anti-VEGF off, and then your CNVM regresses. However, please look at this. This is a patient in which you have got macular neovascular membrane, you've treated it, and over time it has become this. There is no activity, but there is something that looks like a scar. So are you worried when you see a lesion like this? The point is that you shouldn't be worried. Your CNVM has now converted into a group of mature vessels that is doing the job of the chorea capillaris. It is giving nutrition to the RPE where there was no vascularity. So that is what you mean by recapitulation of the chorea capillaris. That is, you have a pathology which is doing the work of normal anatomy. So again, so this was how it appeared before, and this is converted to a larger membrane, filamentous, no activity, but it is providing some sort of vascular nutrition to the retina. These are some other examples where you can see over time it forms a membrane that looks like it's inactive vascularity, and it stays there for long. This is something that happened in 2018. 6 months later, it has increased in size. Even later, it's increased in size. There's no activity. There's no fluid for this patient. So what has happened? This is what you can term a beneficial CNVM, which is giving some sort of nutrition to the retina. Though it's an oxymoron saying a beneficial CNVM. So this is another large residue of CNVM. There is no activity. There's nothing to treat. You shouldn't treat this on just based on the OCTA because it's probably doing the patient some benefit. And you can see that's the same vascular pattern. So this is my last topic, that is what do you mean by scar assessment. So nowadays, what we suggest is you do only treat and extend protocol. That is, you don't do pronto. That's the world is going to treat and extend, but we still don't know how to monitor and when to stop. So we need to know what a scar is. So a scar has different patterns. So I'll just go through these patterns fast. This is called a pruned tree pattern, where you see just branches like a dead tree. You may see large filamentous branches left. Some of these have a tangled pattern. You may see vascular loops, which all may be seen in a vascular scar. So there's something called paucivascularity in a scar. That is, you still see vascularity, but it's not a typical vascularity. As I said, you can see filamentous branches, very large branches of scar patterns. You can see this is a new terminology. It's called skeletonization, that you see a very fragmented or a very thin residue of the original membrane inside a scar, which is not active. So again, this is another skeletonization. Again, a fragmented vasculature which is left behind in a scar. So I'm just going to skip these slides and just show you this one. This is a scar in which there's an activity. So the whole point by learning these OCTA images and their patterns is to see when a scar becomes reactivated. To summarize, I'm going to say that how do you derive information from OCT? You have to derive a whole lot of information during acquisition, find the whole extent of the lesion, assess the different areas, the different depths, verify the orthodicity by ruling out projection artifacts. You have to interpret whether it's a type 1 or type 2 based on cost. That is, whether you need to treat or don't treat. You have to look for signs of activity. Is it a dense network, a fine network? Do you have a perilesional halo? You have to look at features that could tell you probably this patient could have prolonged treatment. That is, you're looking for anastomotic channels, which do not go away easily. You have to look for a discordance between the OCTA features and your OCT or clinical features. Is it a quiescent membrane, or do you have recapitalization? Both of these you don't have to treat, but you have to observe very carefully. You have to really look whether your membrane is beneficial for you. What are the chances of recurrence of the membrane? Or is it a membrane that has eventually become stable and is going to be there for a very, very long time? You get more information from the OCT, angiography from the OCT. And so it's easier said than done. These are three images which are 6 months apart. You have to really look at them, each and every vessel, to actually make sure whether it's stable or increasing. In my opinion, there was increase in activity, which decreased and later came back in these areas. So what does the OCT tell us? I do not agree when we say it's for diagnosis because you do not require an OCT to actually diagnose. It tells you what is happening to the lesion after treatment. It helps you monitor the NV. It would probably, I would say it is really important, it's going to probably tell us our treatment protocols and injection protocols, especially the treat and extend. It is going to tell you when you can actually stop or extend your follow-up so long that you can virtually say that you've cured the CNVM. It is going to tell you when pathological vasculature is finally beneficial for you, and it will help you monitor clinically stable disease. So that is when the OCT angiography for me is going to help and not in diagnosis. So thank you so much, and it was a great opportunity to present in front of the Bombay Ophthalmic Association. Thank you.
Thank you, Dr. Unni. It's a treat to watch those Heidelberg images. It sometimes makes me feel as if I'm seeing through a microscope. But this I think we've turned really a new milestone with the OCT angiography. In fact, I remember a couple of years ago when it was just being introduced to the to the retina world. I remember Dr. Deepak Bhatt, and I can see him. He's there on the in the group. Him telling me that there will come a time where probably we will be treating based on OCT angiography. So far we've been looking at just the thickness on OCT, but these new features, the recapitulation which you said, these things have to evolve now, and probably we'll have to change the way we look at the way we are treating neovascular AMD. But what is your view? I mean, do you still look at the OCT, or you look at both OCT and OCTA when you decide your treatment protocols?
I have to be very honest. OCT is like second nature to all of us. Many of us don't look at the fundus now. You just look at the OCT and you assume you know how the fundus looks like. It's second nature to us. The OCT, I have to say that I am more anxious now after I made the presentation, knowing that I'm wondering whether all the things I have said today will hold true in a year. Point number one. Point number two, I'm very anxious to be very honest. Point number two is that we hardly concentrate. I think it took us 8 to 10 years to finally figure out that OCT was really good for us. Similarly, it's going to take another 3 to 4 years to actually say that use OCTA properly. See, what are we doing? The first 40 slides is what we are doing. We're taking an OCT image, we point at the screen from a distance and say, oh, I see a network, finished. We are hardly utilizing it. Our minds are not turned in the proper way to utilize an OCT angiography yet, which is very sad. It will take another 3 or 4 years, and I hope what I said holds good till 3 or 4 years at that time.
Okay.
Yeah. Dr. Rupak Roy is next. Rupak, can you share your slide? Dr. Pritam, we have 2 questions for Dr. Unni, which we'll take at the end.
Sure. While Dr. Rupak is sharing, you can take one.
Dr. Borse, you had a question. You can directly ask him.
Yeah, Unni, you sort of described the different patterns that you see of the neovascularization. So, have you seen that a particular treatment protocol correlates properly with a particular pattern, or the prognostic factors, or anything of these patterns has got a clinical implications? That's what I mean.
Okay. So the patterns have been described. I mean, there are much more patterns of that. There's an undescribed, indeterminate pattern. See, people are just learning how to describe the patterns. But I think it is more important. I read one beautiful article in which said that if you identify the anastomotic channel, which doesn't go away with a few anti-VEGF, those patients are likely to be highly resistant to anti-VEGF. Those are probably you're identifying a group of patients which you previously called non-responders. I thought that was a really interesting concept. That is, by the OCT angiography, you look at certain features like anastomotic channels or a patient with a high branching index. So these 2 things under treatment, if they don't go away, yeah, you've identified a non-responder.
Okay.
Yeah, Rupak, your slides are seen.
Okay. Thank you, Dr.
Rupak, just hold on. I need to introduce you. You are not there at the start. So we have Dr. Rupak Roy with us. Rupak is ex-Retina fellow from Shankar Netralaya, and then he was consultant at Shankar Netralaya, Kolkata for more than 3 to 4 years. And it's very recently that he has moved on to BBI Foundation. Dr. Rupak Roy is a fantastic orator. We have known him from the grand rounds within SN, and his talks were always sought after. And he hosts a very good quiz also for his state conference. And he has over 100 peer review publications already. So we have with us a budding genius. And over to you, Rupak. Thank you for coming in.
Thank you, Dr. Swapnesh, for the kind introduction, and thanks BOA for this opportunity. We have seen a lot of different types of modalities. I'll try to integrate all the modalities and how they shape up in our clinical practice. So my topic is basically multimodal imaging in retina. That is a term we use nowadays quite frequently. And how in a series of cases, how I'd like to highlight how each of these modalities are helpful in unique ways. So my talk will encompass autofluorescence, OCT, OCT angiography, and multicolor imaging. So autofluorescence, so this is one patient of old CSR. You can see in the right macula, there are some yellowish depositions. The patient has a vision of around 636. This is an infrared. And when you do autofluorescence, you see there is this hypoautofluorescent areas in the center. So when you see a patient of CSR with such amount of hypoautofluorescence, you know you are dealing with a lot of dead RPE, and no amount of treatment will going to benefit this patient. So autofluorescence in this scenario comes as a prognostic indicator. So if you see a autofluorescent feature like this in a patient of CSR, it is probably better not to intervene in the form of laser or injections. This is another case of a 40-year-old male who has a vision of 6/36 and a presence with the complaints of nyctalopia. There are the disc is normal, the vessels are almost of normal caliber. You can see there are some RP alteration nasal to the disc, but there are no typical features of RP here. So on doing autofluorescence, what you're able to see is a trizonal pattern of autofluorescence around the disc. So this kind of pattern is very, very characteristic of a disease entity known as acute zonal occult outer retinopathy or azure. These are the disease. This is one disease which is best picked up by autofluorescence. So autofluorescence is absolutely essential in diagnosing this kind of diseases. So we were able to publish this as a photo essay in IGO. This is another young boy who presented with multiple yellowish lesions throughout the fundus. The autofluorescence was a clincher, so multiple hyper-autofluorescent dots scattered throughout the fundus. So this is a typical case of multifocal Best disease. Best disease again is very high in lipofuscin content. So these are the diseases again which is best picked up by autofluorescence. Now this is another very interesting case. You can see a fundus photograph of a young boy, 10-year-old, shows a lot of hard exudates and a fibrotic nodule. The angiography shows a lot of leakages. Most interesting part, the autofluorescence shows hyper-autofluorescent dots throughout the macular region and the paramacular region. So this is a case of Coats disease, and we were the first to describe the autofluorescence features of Coats disease, and we found out that the Coats disease, the yellowish deposits are hyper-autofluorescent because there is involvement of RB and lipofuscin in them. So how is it clinically important? This is another similar case where you see there are a lot of hard exudates temporal to the macula, but the autofluorescence here is typically silent. On the contrary, you see this is another case of Coats disease where there are hyper-autofluorescent spots. So autofluorescence, so this was a case of FEVR, which we found out which sometimes can have similar presentation to Coats disease, but on the basis of autofluorescence, we can differentiate between a Coats disease and FEVR, though not very important clinically because Coats disease can be very well picked up clinically, but if in case of diagnostic dilemma, autofluorescence comes in real help. Now Now, this is another 55-year-old male patient shows multiple deposits throughout the fundus. Now, on doing autofluorescence, you get this kind of multiple hypoautofluorescent areas throughout the fundus. So this is a classic presentation of a disease entity known as bilateral diffuse uveal melanocytic proliferation, or B-dump. And this is known as the giraffe sign. So this is another very classic indication where autofluorescence is greatly helpful in picking up disease entities. ICGA, we all know, is a gold standard for disease entities like IPCV. So this is a 50-year-old female who presents with this orangish nodule here and a lot of hard exudations. On doing ICG, you can see multiple classical polyps and the branching vascular networks. So ICG is invaluable in diagnosing IPCV. There are other indications of ICG also. This is an 80-year-old gentleman who presented with subtle elevation in the macula with small punctate hemorrhages. The FFA shows leakage in the macular region, but the ICG in this case was diagnostic. You can see there is a hotspot with the anastomosis of the vessels. So this is a classic case of retinal angiomatous proliferation.
Rupak?
Yes.
Rupak, can you use your headphones or talk a bit loudly? We can hear you, but there is some disturbance.
Okay, I'll speak up a little loudly.
Yes. Yes.
So this is a classic case of a RAP lesion which can be picked up nicely on ICGA. Another area where ICGA is very useful is retinal arterial macroaneurysms. Here you see the macroaneurysm is nicely picked up by the ICGA. OCT is an invaluable tool. Retinal arterial occlusions can be seen as thickening of the inner retinal layers, which can be picked up very nicely by the OCT. This is a very interesting case of a 45-year-old gentleman who presented with sudden onset scotoma in the left eye. On fundus photography, you can see an area of whitening in the just paramacular area. The multicolored imaging highlights the area as green. On a spectral domain OCT, you can see there is classic thickening of the middle retinal layers only. So this is a case of paracentral acute middle maculopathy, which is again best picked up by a structural OCT. This is another young 20-year-old female who presented with acute onset scotoma again. Here you can see subtle RP alterations just below the fovea. On a magnified OCT, you can see subtle alterations in the outer retinal layers. So this is a case of acute macular neuroretinopathy. So these two disease entities, the paracentral acute middle maculopathy and the acute macular neuroretinopathy, are disease entities which are due to ischemic process and are best picked up on structural OCTs. This is a 40-year-old lady who presented with subtle distortion of vision in her right eye. As you can see, the fundus photograph is unremarkable. The autofluorescence does not pick up anything. The fundus fluorescent angiography is also silent. But once you look at the OCT very carefully, the structural OCT very carefully, you're able to see there is subtle loss of the RP layer. So this is a case of RP epithelitis, which responds very wonderfully to oral steroids. So these are subtle lesions which are not picked up by any other modalities, but by structural OCTs only. Now, with the advent of EDI imaging, we are able to see more into the choroid. So this is a case of intrachoroidal cavitation, which is seen as a cavitary element, just peripapillary. So these are the patients who can sometimes give rise to false visual field defects. So clinicians must be aware of these lesions so that they don't confuse them with glaucomatous lesions. Also, we can see choroidal excavations, that is backward bowing of the RP layer. These are also clinical features that can be seen on structural OCT, structural EDI OCT. And if the choroidal excavation involves the foveal region, though the fovea will look clinically normal, the patient will have some normal vision. So it is important to diagnose these disease entities. OCT angiography, there has been a lot talked about OCT angiography. The classical indication is obviously CNVM. But this is another interesting case where you are able to see in the right eye there are certain RP alterations. In the left eye also there are certain RP alterations. In the right eye OCT is normal. The left eye OCT shows an area of subretinal fluid and an area of double layer sign, and there is thickened choroid or a pachychoroid. And on doing an on-fast OCT, we see a large dilated choroidal vessel or a pachy vessel. And the OCT angiography in this case is a clincher. You can see a tangled network of vessels. So this is a case of pachychoroid neovasculopathy, which is a part of the pachychoroid disease spectrum, which is again picked up with the conjunction of a structural and a OCT angiography. Now, finally, I come to multicolor imaging. It's an innovative technology. It basically involves three kinds of laser lights: the blue, the green, and the infrared. The blue light is for the inner retina and the vitreoretinal interface. The green light is for the retinal hemorrhages and blood vessels, and the infrared is for the RP layer. So the multicolored image is a composite image with components of a blue reflectance, a green reflectance, and an infrared reflectance. So there are three images which combine to form a pseudo multicolored image. Now this is a patient. You can see there is some RP. There are areas of a fine epiretinal membrane in the macular region on the classic color fundus photograph. But once you do a multicolored imaging, see how beautifully the ERM stands out as compared to the color fundus photograph. So multicolored imaging is very efficient in picking up the areas of epiretinal membrane, and sometimes it can be used to find an area of cleavage from where to start the surgical peeling in cases of where surgery is planned for epiretinal membranes. This is another patient. The left eye shows mild graying of the macular region. But what is most important is you see this blue and the green reflectance images is showing areas of increased reflectivity, and the multicolored image is showing an oval area of greenish reflectivity. So this is a case of parafoveal telangiectasia, which is most efficiently picked up by the blue reflectance imaging. The color fundus photograph here, as you can see, only picks up subtle changes, but once you look at the blue reflectance and the green reflectance, you're able to see how nicely they stand out. This is a patient with diabetic retinopathy with dense asteroids. All of us has seen patients like this and have trouble in visualizing the macula in these cases. So in this patient, as you can see, there is a lot of dense asteroids. We do not have any clue what lies underneath. But once you do a multicolored imaging of the same patient, you are able to pick up hemorrhages and hard exudates in the foveal region. So you see the color fundus photography here is not able to pick up anything. But once you do a multicolored image, you are able to pick up nicely the hemorrhages and the hard exudates. So this is one great indication of multicolored imaging to find out the anatomy and the lesion characteristics in eyes with dense asteroids. This is a young lady who presented with subretinal fluid in the left eye. You can see there is a cystic area in the left eye. The disc is absolutely normal. Once I do a OCT, I find a structure like this with a outer layer hole and an inner and outer layer schisis. So basically, a OCT picture like this is screening of optic pit maculopathy. But once you again examine the disc very carefully, you are not able to find any pit. Herein again, the multicolored image comes to a rescue. You can see a very nice pit that can be seen temporal to the disc, inferotemporal part of the disc, which is not at all seen in the color fundus photograph. So this is another indication where we are suspecting occult pit. We can try out multicolored imaging to pick up those pits. Sometimes we have clinical situation where you have a lot of medullated nerve fibers contiguous to the disc, and we have struggled to identify the disc margins. So here you see the color fundus photograph shows medullated nerve fibers contiguous to the disc, and you are not able to identify the edge of the disc or the cup properly. But once you do a multicolored imaging, you are nicely able to delineate the disc margin and the cups. And also you are able to see subtle NVEs at the margin of the medullated nerve fibers, which is not visible in the clinical, the fundus photograph. This is another case of a 45-year-old patient, of an old CSR patient. The right eye is absolutely normal clinically. The patient came with a sudden onset scotoma in his right eye. The left eye shows some areas of RP alterations. So the OCT in the right eye, OCT is right eye, or the structural OCT in the right eye is absolutely normal. The left eye shows old changes and the RP atrophy can be seen. Now see the multicolored imaging of the right eye. There is an area of altered reflectivity just around the disc. On inquiring the patient is a dentist by profession. He had a laser exposure to his right eye on working with the laser. So you can see in the right eye, the multicolored imaging picks up the area of the retinal affection, which is not picked up on clinical. This is the clinical photograph. You are not able to pick up here anything. But once you see the multicolored imaging, you are able to see there is an area of afflection of the retina, just parapapillary and abutting the fovea. Also, the component images also shows the same. So it means this is the green reflectance, this is the blue, and this is the infrared. All the reflectance images shows that the area of the bleaching of the retina in the same area. So so that means all the three layers, all the superficial, deeper, and the RP layer is affected by the laser exposure, which is not picked up by clinical ophthalmoscopy or OCT, only picked up by multicolored imaging. So these are the cases where multicolored imaging helps us immensely to pick up subtle lesions and maybe a very important imaging modality in future days to come. Thank you very much for your patience here.
Thank you, Rupak. That was a great collection of cases. And thank you for sharing that with us. Dr. Preetham. Dr. Borse can share his slides. Since we are running short of the time, we'll take the questions at the end. Dr. Preetham, sir. Oh, so you can unmute yourself.
Yeah. I think let's go with Dr. Nishi's talk, and then we'll have some questions.
He's still muted. Yeah. Okay. So we can't hear you.
Can you unmute him?
He is unmuted.
Yeah.
Yeah. Can you hear me now?
Yes. Loud and clear. Go ahead.
Okay. So the last topic is, I think, totally different than what we were going in, and that's why I think we decided to take it as the last topic rather than the OCTAs and the OCTs which were coming in, because we didn't want the flow to get disturbed. Now, this is about patients as partners, and I think this is a new concept that we are having in our clinical practice. Now, we have to understand that the patient's perspectives are very unique, and they give us the first experience of what we have given to them about the care pathway. Now, if you look, the basic problem is the quality of our care and services is often evaluated by other doctors or other healthcare professionals, and we really never see into the patient's expectations, what they need, and their perspectives, which many a times are remarkably different, and we don't understand them. And that's why it is important that we have patient as partners for us to understand how to go ahead giving them the best of the quality of care and what they really need. Now, this concept might sort of sound new but it has always existed in our clinical practice because we try to understand what the patients want. But it has been definitely given a formal sort of a formal pattern in countries like US and Europe, where there are actually groups called as patients as partners and patients in Europe, and they actually do have annual conferences which are conducted. You can see some flyers of them here, because they would make them understand about how to give better outcomes and better treatments to patients by engaging the patients themselves as partners in treatment. And I think that's a great concept that we need to take in India as well. Now, why it is so important is basically because as a patient, the patient develops a lot of knowledge from the experience of what he's gone through, the psychosocial problems that he's gone through, and how the care progresses. And what impact has these problems, what is the impact of these problems on his personal life, and also that of his household, and how we can actually help him through this disease. Now, this is not so much in acute cases because there the patient just comes and goes, but in chronic disease, it definitely plays a big role, because in chronic diseases, it is not just the patients who have, they have to be made their partners in their own healthcare, because we can, if you take them as a partner, then we can deliver the healthcare more effectively and efficiently to them. When you come to ophthalmology, I think it is the AMD and diabetic disease that would definitely come to our mind as the chronic conditions that we are usually focused on in our retinal practice. And these are the conditions which definitely need repeated visits, repeated treatments, repeated injections, and they do contribute to a significant financial burden and dependency for the patient. Now, we know that diabetes is a rapidly growing disease in our country, and diabetic retinopathy we are seeing more and more in our clinic as the days go by. And if you really see carefully, we'll see that majority of our diabetics have at least one comorbid condition, and at least up to 40% have at least three. And that increases the number of appointments that the patient has to go to various doctors. So we most of the time end up looking from the eye perspective, but if you look at a patient perspective, the patient has to go in for a numerous appointments. Now, this is a fantastic study done by Kiss et al., which has been published in Clinical Ophthalmology. And you can see that if you take a diabetic patient, nearly 20% of the patients that we deal with, even if they don't have DME, they have renal diseases, or they have stroke, cerebrovascular diseases, peripheral vascular diseases, and etc., which makes it mandatory for them to visit other clinics. And that makes diabetic care very expensive, especially in countries like us, where most of the incomes are low or middle income cases. And if you look at a DME patient, in 6 months, on an average, they need to come monthly to a retina specialist and a nephrologist, and they have to nearly go every 6 weeks to a diabetologist, or once in 2 months, 3 months to a cardiologist. So you can see the number of visits, if you just total them up, it comes to nearly 17 to 18 visits to various doctors that the patient has to take in 6 months. That goes to nearly 3 visits every month to various consultants. And there, if you look at the various treatment expectations, ease of travel and cost, then we'll understand that the perspective for the patient would be for us to reduce the number of injections itself. Like if you go even for PRN, for anti-VEGFs, you will see that the median injections, they decrease from the first year onwards. But when you go to diabetic mellitus, you will see that the number of injections are taken properly in the first year. But as they visit the other consultants over a period of time, between 2 to 4 years, they start reducing to 1 or 2 injections only, because the frequency of the visits gets reduced because they give importance to the other conditions. And when the TAB increases, we need to, by the time they come back in the 4th and 5th year again, they need more injections to set back the patterns back to normal or to recover the visual acuity. So how can we partner with the patients in DME? We have to look at definitely reducing the number of injections. We have to look at reducing the number of visits. and thereby reducing the financial burden that the patients and their family has to face. And it may not be only in DME, but also in RVO, where the number of injections are very high, and we should definitely look at reducing the number of injections. Now, if you treat the patients with the most of the time the preferred therapy that we have anti-VEGF, we will see that the mean number of injections needed are anywhere between 5 to 6. Whereas if you look at long-term treatment agents like DEX implants, there we can reduce the mean number of intravitreal injections down to between 1 to 2. So if you see there's a significant difference in the number of visits the patient needs when you change from anti-VEGF to a steroid implant, thereby giving the patient a longer acting agent and thereby reducing the number of visits the patient and the relatives need to come down to the retinal clinic itself. And fewer injections when you give, it also reduces the burden of care for the patient. Now, but do the fewer injections translate to a real good visual acuity? That's another question. Well, various studies have shown that there is a good amount of satisfactory visual gains, anywhere between 7 letters to 9 letters that have been seen in various studies. And there is one study by Acne which actually shows up to 16-letter visual gain that you can achieve with a DEX implant itself. So by shifting these patients to DEX implant, we are not only reducing the number of injections, the number of visits, but we may not compromise on the amount of visual acuity gain as well. Now, coming to the current situation and the current pandemic, you will have to understand that the patient undergo more anxiety when they have to visit a medical facility, because that's where they're exposed to other patients. And you can find out that a patient is quite anxious when they need to visit a medical facility during this pandemic. And if you look at various studies, there are a lot of patients who are uptight, they're unable to actually relax, and they are affected to a great extent because of the burden of visiting various clinics, especially in the current pandemic. And there again, we would like these patients to visit our clinics lesser and lesser. And that's where, again, a long-acting implant would come into our help, reducing the number of visits they will have, especially during the pandemic, and keeping them safe away. Now, what happens with the cost? If you look at the average cost of injections, this is about Avastin, say 20,000 rupees is the cost of the injection, and 3 to 4,000 was the average price of injection. So this is where a monthly injection of Eccentrics will cost, and this is where a monthly injection of Eylea would cost. But when you go to Ozurdex, this is the cost of the injection and the procedure, which is on average, which is data collected by the Allergan. And if you divide it by 3 to 4 months, then you can position it somewhere around the Avastin cost. And thereby we can give the patient a good quality care at a reasonably good value of treatment. So in summary, amidst this pandemic, we should consider towards the patient and treating doctors for reducing the number of visits and also thereby improving their quality of life and reducing the anxiety that they go through. In chronic pathologies like DME, we need to consider a longer acting intravitreal such as Ozurdex, and that will help them to be safe and also reduce the burden. Thank you.
Thank you, sir. So can we take a few questions, just one question per speaker? Dr. Preetham, sir.
Yeah, I think that was a very relevant talk in today's times by Dr. Nishikant. Considering the increased cost, the burden on all the treatment with these injections, I think making the patients as partners would go a long way.
Yeah, I agree. And we really need to look at having something in India too, as a body called Patient for Partners in India.
Absolutely. Even to make the patients probably understand the implications of insurance in some of these, to get these injections probably, and the cost of the treatment. probably there also it will help to get the patients on the same sort of wavelength with the doctors.
Yep, absolutely.
We have a couple of questions. There's one question for Dr. Muna Bende madam. Is Dr. Madam there? Ma'am? Dr. MBB ma'am?
I'm there, I'm there.
Yeah. Madam, there's a question here for you where someone has asked that, routinely in inherited retinal disorders, as a routine, we used to normally look towards electrodiagnostic procedures.
Yeah.
To diagnose and probably even to follow up over a couple of years.
Yeah.
With so much of information that we get on OCT, which is done in inherited retinal disorders, how do you look at it? Do we complement electrodiagnostics, or maybe we can do away with electrodiagnostics, just do it once as a baseline?
Yeah, electrodiagnosis is necessary. It's not that it's not necessary, but very often the lack of electrodiagnostics is being used as an excuse for not investigating the patient further. So, and especially with gene therapy and a lot of implants coming up, electrodiagnostic confirmation is definitely needed. You do gene testing, you would like to correlate everything.
Okay.
Having an OCT does increase your understanding, not only OCT, a good fundus photograph, a good autofluorescence image, combined with electrodiagnostic testing, if you have it, definitely is a good idea.
Okay.
I would think OCT has become more and more important. We looked at it very skeptically earlier, but now the newer OCTs are giving us a lot of information. So I think it's necessary. You can't get away with electrodiagnostics.
Okay.
Point it's needed.
Madam, where would you wish that you would use OCTA in these particular cases? Like one example is probably BESS, to pick up a CNVM along with BESS.
Yeah, no, I do use OCTA for electrodiagnostic, but I thought it would be too long in the talk since everyone was speaking on it. Yes, BESS dystrophy, definitely yes, especially when it occurs in slightly older people and you just see a yellow patch and you don't have access for electrodiagnostics to confirm with EOG that it is BESS. I do use it. There's a lot of new literature on OCTA in all these conditions where they show changes in choroidal vascularity, choriocapillaries density, loss of ellipsoid zone. Definitely it is there, but possibly still a little in our infancy. So currently I would say used to detect CNVM would probably be the most practical approach for OCTA and inherited disorders.
Okay. Swapnesh, you can unmute everyone, Dr. Nishikant.
Yeah, they can unmute themselves. I'll try to individually.
Dr. Unni probably.
Yeah, we have a question for Dr. Karthik also. Can I ask that?
Yeah, please.
Yeah. So, Dr. Karthik, what is, there's a question on YouTube chat. What is projection resolved OCTA?
I think that is, I'm there. Am I audible? Yes.
Yes, yes.
So, yeah, so I think the most of the newer OCT equipments have techniques to correct the projection artifacts that we were seeing on the OCT angiogram. So those are algorithms again that have been incorporated into the OCT to resolve this projection artifacts. But I think these all hold good when we are looking at a relatively normal macular structure. When there is a pathology, I think manual segmentation takes the lead, along with looking for whether there is a similar pattern that's happening between the layers. So we can conclude it as projection artifacts. I think Dr. Unni also can add more to it.
Dr. Muna has answered that there's an option of switching the projection on and off.
Yes.
Yeah, in that particular thing. Dr. Unni, would you like to add something? And there is one more question for you.
That is, see, the projectional artifact removal. It's called PIR in the Heidelberg system. Essentially, what it does is that it toggles between having the projection removal on or off. And the natural thought process is why not have the projection removal always on? we also have to understand that when you remove artifacts, you also remove a lot of data. So that is why the option of toggling it on and off is also there. So as you said, the projection artifact removal in some machines is done by something called a probabilistic approach. That is, the algorithm calculates whether the adjacent pixel is 50% dark or 50% lighted, depending on the nature of the pixels around it. So that is how one of the methods in which a projection artifact is removed. So in certain layers, see, why is it called a projection artifact? That's the most important thing. It's like a lamp. It's like a what do you say? The lamp,
Screen and
LCD
a lamp.
projection. You have a lamp and you have a projection sheet. The projection sheet is any plexiform layer. Any layer of any plexiform layer is the projection sheet. So when you have excessive signals in those areas, they are compared to other signals adjacent to it, and that is how it is removed. It's purely an algorithm. So when the algorithm is always working, not only do you have the projection artifacts removed, you have a lot of data removed also. So that is why some machines it is mandatory, some machines you can switch it off at some times. So that is how it works.
Maybe like perimetry, like there is a foveal threshold, and the threshold of the next point determines what color. A similar chorology to that.
Yeah, it could be that. That is a probabilistic approach.
Yes. So there's one question from Dr. Anand Subramaniam for you. How can you differentiate between BVN and type 1 membranes on OCTA?
Yeah, I was cheating. I saw this question about 5 minutes ago and I was thinking about it. So it's like, to my knowledge, all BVNs are type 1 membranes, but type 1 membranes are all type 1 membranes BVN. So that was the thing here. So there is a study about the types of BVNs. So we assume that BVN is what you see in PCV. It is not. A lot of things are called BVNs, branching vascular networks. The BVNs associated with the PCV are the ones we see with pachychoroids, are the ones we call BVNs with polyposis. So BVNs are divided into, I think, sticks, trunks, and glomeruli, I think. So the trunks are the ones that you see with pachychoroids. Sticks are the ones that you see with SRF and pore resolution. Glomeruli are the ones that you can see in type 1 membranes. So it is not necessarily that BVNs are different from type 1 membranes. They are a type of type 1 membranes, essentially.
Okay, thank you. And Dr. Borse has asked question for Dr. Rupak. How close is multicolor imaging to traditional red-free images, etc., from a fundus camera?
So that is a very pertinent question, sir. So basically, the green reflectance image is similar to the red-free image. But we know that multicolored image is not only the green reflectance image, it is composed of the blue reflectance, the green reflectance, and the infrared. So it gives a information from combination of 3 images. So as you saw in my presentation, the blue reflectance part picks up the PFT nicely. So similarly, and green reflectance imaging, the green, so the red free is similar to the green reflectance, but multicolored imaging adds much more because it has added blue reflectance and infrared reflectance, and also because of the confocal scanning, it gives you scanning ability in a small pupil, higher contrast, and a hazy media, which is not available in traditional white light photography, which you use for red free images. I think that will be the key difference.
Yep. Thank you. Thanks a lot.
So that's all, sir. Those were all the questions.
We've come to almost 2 hours. You know, this is a fantastic session we've had with so much of good points, knowledge, fantastic images being shown. I thank everyone. Swapnesh, can you give the official vote of thanks to all the speakers who were here today?
Yes.
And lastly, don't forget to thank Allergan.
Yes. So first, thank you, Allergan and Mr. Kumar, for all your support and spreading the word about this CME. And BOA thanks you for that. And thank you very much, Karthik, Rupak, for chipping in and giving your inputs on the latest imaging techniques. Dr. Borse sir for giving a clinician's perspective about the latest in how patient management and patient financial management basically for the anti-VEGF therapy. And Dr. Unni, thank you so much. Your presentations on OCTA are to be viewed again and again to understand them better. So there's one more video for us to revisit. And as usual, MPV madam, thank you so much for a very lucid presentation on a very rare but very important topic. And madam, you have so many images. So the second, third, and the fourth atlas for SN is already ready, and we are looking out for that when it is going to be out. Thank you, madam, so much for chipping in. And thank you, Preetham sir, for allowing me to think of this and helping me in organizing all of this.
Thank you. Thank you, everyone. And have a great remainder of Sunday.
Thank you.